energy per square foot than other commercial buildings. This is largely due to our spatial footprint and 24/7 operations and all the equipment we have. Hospitals are the third most water-intensive public buildings after senior care facilities and hotels, and use about 570 gallons per staffed bed per day of water. In addition, that water is often treated, heated, and chilled, further contributing to our impact. We're going to talk about waste a little bit more in another slide, but U.S. hospitals generate about 29 pounds of waste per patient day. And then if we look at supplies, anyone who's been in a hospital knows that hospitals are filled with supplies and materials and equipment. We have fleet vehicles, including the ambulances and our own fleets. Waste anesthetic gases, we often talk about that in the OR, but there are emergency departments who are using nitrous oxide in their departments. Meat production and food transport. Hospitals serve a lot of meat to their staff and patients and visitors, and about 14.5% of global greenhouse emissions come from the livestock sector. And hospitals can make a big difference by serving less meat. And employee commutes also contribute to our impact. I wanted to go into a little bit more detail about a few of these impacts. This is a study that's often quoted, done by my colleague, Dr. Jody Sherman, with Matt Eckelman. And I think this is just a remarkable statistic. If the U.S. healthcare were ranked as a nation, it would rank 13th in the world for emissions, ahead of the entire UK. I mean, think about that. I think that it's just a staggering statistic. This is a slide which I thank Practice Greenhealth for making, looking at the common greenhouse gas emission sources in healthcare by scope. And I want to draw your attention to scope 3. That has the biggest impact, and I think it is also the area where we as individuals can take personal action and have impact. Supply chain. Healthcare, as we talked about, has a huge supply chain. It's often the second largest expense in healthcare following labor, and it's anticipated that supply chain costs might overtake labor by 2022. And the purchasing volume of the top 4 healthcare GPOs is over 189 billion. Again, I think that's a staggering number. Oop, I'm not advancing here. Waste. I want to talk about waste. I really got my start in this work looking at healthcare waste. As we talked about before, hospitals generate about 29 pounds per staffed bed a day, and that's about 14,000 tons of waste per day in U.S. hospitals. A lot of this is plastic waste. Some of it is infectious or hazardous waste. Some of this increase in waste has to do with single-use disposables and packaging, including pharmaceutical packaging. Pharmaceutical packaging is a $20 billion industry and expected to grow. I mean, anyone who works in healthcare, who works in an emergency department, has been through a code type situation in our trauma rooms, know what the floors can look like after we break open our pharmaceuticals. And if you look at this this graphic on the right, and you look at the different type of waste in healthcare, we have all of those wastes, or just about all of those wastes, in our emergency departments. I think one of the most impactful things that can be done in emergency departments is to reduce the number of red bag waste bags, which are often overused in emergency departments. When I started doing this work, we had red bags in every single room in our emergency department, and we're able to cut that down. I want to talk about hospital food a little bit. I would like to, this is a real life picture on the left of food served to a patient, and I think we can do better. I have a philosophical problem that I mean, we all know that hospitals do not have the best reputation for food, although that is changing. And I always find it very ironic that at times hospitals are serving food to patients that are contributing to the diseases we treat. I just find that very ironic. I think we can do better. I think, and we are doing better under the leadership of Healthcare Without Harm and the Healthy Food and Healthcare program. Hospitals are beginning to serve climate healthy food, serving local sustainable food, serving less meat, better meat, having healthier choices in vending machines in the cafeterias, and really aligning our food services with hospitals' mission to protect health. This is Antibiotic Awareness Week, so I wanted to include this slide. I want to back up a little bit and say that the primary focus of this webinar is about promoting climate-smart healthcare, but healthcare's only impact is not climate. We have other impacts too, which I'll get to in a minute. Again, I wanted to talk a little bit about the antibiotic work that Healthcare Without Harm is doing. You may or may not know that antibiotic overuse in animal agriculture is contributing to antibiotic resistance, and 70 to 80% of the antibiotics used in this country are used to treat or to be given to animals in animal agriculture non-therapeutically. And Healthcare Without Harm is leading a national initiative working with hospitals to encourage them to not only serve less meat, but to procure meat that is raised without non-therapeutic antibiotics. Chemicals in healthcare. Many chemicals in healthcare which can have health impact. Mercury was really the first chemical we looked at in thermometers and blood pressure cuffs. That has largely been eliminated. But we have other chemicals such as DEHP, a plasticizer which is put in plastics such as IV tubes, and it can leach into the fluids and into the patient. It's an anti-androgen, can have effect on young males. I'm not going to go through all these chemicals here. I do want to just briefly mention cleaning chemicals. I don't know how many of you who work in emergency departments have been in the department when they wax and strip the floors. So I think you have, if you have a sense of, how irritating that can be. So I think that's a lot of, sort of depressing news, but there is lots of ways to take action by looking at your energy use, investing in renewable energy, including climate risk in your preparedness plan, reducing waste in the emergency department, or recycling, advocating for healthy food to be served in your emergency department and hospital, educational programs, many opportunities to take action to reduce your climate impact. This work is, I want to talk a little bit about Practice Greenhealth, which is Healthcare Without Harm's partnership organization. If you're interested in knowing if your facility is a member, just shoot me an email. Practice Greenhealth is a membership organization for healthcare facilities interested in reducing their environmental impact, and they have tools and resources for everything. On the left-hand side, you'll see a list of some of their initiatives, and they, as I said before, they really offer solutions for anything that you might be interested in implementing at your hospital. I want to talk briefly about the Healthcare Climate Challenge, which is a global challenge to engage and mobilize healthcare institutions around the world to take action to protect the public from the health impacts of climate change. So there are many hospitals in the U.S. Who are participating in the climate challenge. What exactly is it? It is a challenge asking hospitals to take action in 3 areas: mitigation, resilience, and leadership. So we want to see progress in hospitals reducing their climate footprint, preparing for the impacts of extreme weather, and also educating the staff and the public about climate and health. This is a slide that highlights remarkable climate leadership from the healthcare sector and some of the amazing progress that has been made in hospitals across the country under the leadership of Healthcare Without Harm. So what exactly is climate smart healthcare? I use this term a lot, and I get asked a lot, what exactly is climate smart healthcare? So this is a report put out by the World Bank and Healthcare Without Harm last year, which is a comprehensive summary of what climate smart healthcare is. Basically, we want climate to be included in building design and construction. Hospitals can work on energy efficiency, renewable energy. A climate smart healthcare hospital is working on waste minimization, waste management, resilience strategies, and low carbon procurement for our supplies and pharmaceuticals. So in my role, I work with physicians, encourage them to advocate for climate smart healthcare in their facilities. So why should physicians advocate for climate smart healthcare? We all took the Hippocratic Oath. Of course, we don't want to do any harm to our patients, but I think we can put an environmental lens on the Hippocratic Oath and also make sure that we are working to ensure that our healthcare operations are not harming our patients, our employees, our communities, and our environment. I think, at least I use this approach. I really looked around and I thought, are any of our hospital operations contributing to the conditions that we are treating? And, I realized that they were. So I encourage you to ask that question. And, if the answer is yes, look around and see what you can do. Our medical societies are encouraging physicians to lead sustainability efforts in their healthcare organization. This was a piece in the AMA Journal of Ethics last year that asked, are physicians obliged to lead sustainability efforts in healthcare organizations? And they concluded that yes, physicians do have an obligation to use our influence, expertise, and resources to promote sustainability. So why specifically should emergency physicians care about this impact? It's because we are a part of the problem. We don't know for sure what our impact is, but we believe our impact is large. We have 24/7 operations. We are open every day of the year. Many emergency departments have large spatial footprints requiring lots of lighting and heating and air conditioning. We can have a large workforce. We can have large patient volumes. And those patients and those employees are coming to our hospital, so transportation is an issue. We have a large supply chain, including pharmaceuticals. We generate a lot of waste, and we also have high-risk patient populations. Because we often are seeing a patient just once, we have to make the most of that interaction with our patient, and we tend, myself included, to over-order tests because we really don't want to miss a diagnosis because we have that one chance to get the diagnosis right. So the first time we did this webinar, I talked about how emergency medicine was behind in coming up with policy about climate and health, and I want to share this policy, which was passed this year. And as part of their policy, they are calling on emergency medicine physicians to reduce the carbon footprint of our emergency department. So our medical societies are asking physicians to take action. So a little bit of my personal opinion why emergency medicine physicians should lead. We are shift workers, which means we do have the time. We do have the time to be available for meetings and to do this work given our schedules. We're also hospital-based clinicians. If you look at the physician specialties that are leading sustainable health care, it's really the anesthesiologists, the emergency physicians, we're seeing radiologists. It's really hospital-based clinicians because we work amongst the impact. We come face-to-face with the impacts and opportunities every single day. And for me personally, it's been a remarkable way to promote wellness and avoid burnout, I have really found having mission-based non-clinical work, really important in giving me some longevity to stay in the emergency department. And finally, it's fun and it's super, super rewarding. The picture on the right is my green team, which I led for 7 years. If you're wondering what we're wearing, we are all wearing clothing made out of sterile blue wrap, which was used to wrap surgical instruments in our emergency department and OR. So I lead a national physician network for healthcare without harm. We are a group of physicians who are interested in promoting climate smart, environmentally responsible healthcare. I encourage you to check out our website, learn more about us, and join. There's no obligation to join, and joining will allow you access to our resources. You'll be part of a community of physicians who will be willing to share resources and best practices. So I encourage you to check it out and join us. Those are some of our physician network crew at CleanMed last year. We also have a Facebook group, Physicians for a Sustainable Future, which is another platform where I share resources, educational and advocacy opportunities. I encourage you to join that if you are on social media. I also encourage you to join us at CleanMed, which is our annual conference. It's going to take place in Nashville from May 7th to 9th, and we expect to have a good number of physician-led CME-eligible sessions. So what can you do today? I would encourage you to get educated, look around your emergency department for opportunities, find out if your hospital has a green team or a commitment to sustainability. If it has a green team, join it. If not, start one or start a Greening the ED committee. Find out if your hospital is a membership of Practice Greenhealth, join our network, and ask your hospital to commit to the climate challenge. I would now like to introduce my colleague, Jonathan Slutzman. He is an instructor in emergency medicine at Harvard Medical School and Massachusetts General Hospital. He's a former associate in environment and risk management at ICF International and Arthur D. Little. As a former engineer, he is a member of the Healthcare Without Harm Physician Network Advisory Committee, and he has a research interest in measuring the environmental and financial costs of healthcare services. Thank you, Jonathan.
Thank you, Amy. The one correction I will make is I don't think I can ever be a former engineer, so I will always be an engineer, and I take that pretty seriously in my medical work. So what I'd like to expand on what Amy has talked about for the last little bit on delivering climate smart and environmentally responsible healthcare, more specifically how we can advocate and leverage and engage the emergency department with their unique expertise to mitigate many of the challenges that Amy has just outlined. I want to start by kind of couching this in terms of resilience, that really we need to understand that the striving, the goal of improving our environmental performance is not just about protecting the environment, it's also about contributing to the overall power of our hospitals, our healthcare institutions, and most specifically our emergency departments to respond to unforeseen, unpredicted, and unexpected demands, and then to resume or continue normal operations afterwards. That's the definition of resilience, and from a practical perspective, it's the ability to go from this, which is one part of my emergency department on one day of the week at a late evening time, to go from this to this, which was just a few hours later in that same emergency department on that same day, potentially even to this. And this photo was taken, I can't quite read the clock, but I think around 4 o'clock in the afternoon on April 13th, 2013, which was a little over an hour after the Boston Marathon bombing, where we had, in the span of a couple of hours, quite a number of dozens of patients arriving just to our hospital. And then we go back to that. And that's a normal operating regime in our emergency department, and I suspect it's that way in your emergency departments as well. You see a bunch of features that contribute to resilience on this tracking board. You see people in hallway beds. You see that there is a level of staffing that's sufficient to target somewhere around the 75th or 80th percentile of our expected patient needs. And you kind of see the fact that we have the right patient going to the right place at the right time, whether it's this particular pod or one of the others that you're not directly seeing on the screen right now. But those are just the things you're seeing. There are a number of resilience factors behind the scenes that you don't see. Things like effective disaster planning with drills, a leadership commitment to supporting our patient care needs, some pre-placed equipment in various locations around the department, including just-in-time training and labels for our staff. We have infrastructure that's specifically designed without single failure modes or single failure nodes. We have effective site access control, and almost most importantly, we have a devolution of authority in that any single attending emergency physician in our department can activate the entire hospital disaster plan, which would trigger quite a number of resources to meet the needs of any disaster that we might face. Now, kind of getting more into the specifics of climate change and environmental hazards, I'm going to take a page from my colleague who you heard from 2 webinars ago, Jay Lemery, who couches climate change as a disease. We physicians are very good at categorizing syndromes and symptoms and problems into disease frameworks. So climate change is a disease of a number of things. It's a disease of greater infections through vector-borne illness and a number of other routes and factors. It's a disease of respiratory distress with increased particulate matter. I see that some of our colleagues are in California are on this webinar right now and are certainly facing that hazard every day for the last number of days, unfortunately, with increasing risks to respiratory patients. It's a disease of food insecurity. So as climate changes, we're going to see changes in growing seasons, in the nutritional value of our crops, and our ability to provide adequate nutrition, safe nutrition, to our populations. It's a disease of waterborne illness. So we're going to change the constituents of our surface water bodies. We're going to change the makeup of our groundwater bodies as well. And that's going to impact the health of our people. It's a disease of heat stress. That's the obvious one. As temperature increases, we're going to have greater number of days of excessive heat throughout the country. We're going to have excessive heat in areas of the country that really aren't used to experiencing it. It's a disease of mental illness that some of our colleagues are much more aware of than even I am. We have seen reasonable evidence that exacerbations of underlying mental illness are worse in a setting of climate change. And finally, it's a disease of displacement and trauma. We have migrants crossing borders, partially as a result of climate change. The correlation between increasing temperatures and economic and political unrest is remarkable. And even on a local level, our trauma surgery colleagues have talked for years about what they call fighting weather, that the warm evenings in the summer are quite dangerous for interpersonal violence. And we know that on a larger scale as well as climate change happens. So you put all that together and climate change really becomes a disease of two things. It's a disease of vulnerability and disaster response. And if you, right now, I want you to think a little bit about who in your hospital, who in the House of Medicine are the people who are best suited and best trained and most used to taking care of vulnerability and disaster response. And I think many others would then tell you that it's emergency medicine. We know disasters. We have been there. We plan for them. We manage them. We wrote the book about them. And climate change is really proving to be no different than any other disaster where the need for resources outstrips our ability to provide resources. Now the question is, how can we in the emergency department really contribute to the discussion? And the first is talking about disaster preparedness. That think for yourselves. If we were all in person, I would ask each of you to answer this question, but I want you to think for yourselves how many of your organizations have completed hazard vulnerability analyses for your hospitals. I would wager that that the vast majority have, if not all of them. How many of those reference changes in natural hazards related to climate change? Since we know that they're going to change. What you see here is an image that I gathered many years ago. You have two hurricanes from the exact same satellite, the exact same angle, at about the same time in the course of the storm. And on the right, you have Hurricane Andrew, which made landfall in Florida in 1992. It was a huge storm that caused immense damage and loss of life. Not 7 years later, Hurricane Floyd on the left struck Florida, and you can just see from the imaging that is a drastically larger storm. Now, I'm not going to make the case for you that this is a rigorous scientific study, but I think you can trust me on this, that storms are bigger and more frequent, and that's going to impact our facilities' ability to respond and to continue to operate. We in emergency medicine have the skills, have the experience, have the knowledge to contribute to resilience and disaster preparedness. So what I would recommend to you is that our facilities can leverage the expertise of the emergency department in planning, especially since the emergency department is a site for buffering capacity. It's a site at risk of inundation, both of patients and frequently our EDs are on the ground floor or sometimes even below the ground floor. So we are literally at risk of inundation. And we're well versed in collaborating with everyone else in the hospital, which I'll get into a little bit more in a minute or two. We should be encouraging our facilities to incorporate climate change within all hazards planning. I'm a strong advocate for all hazards planning. We should have disaster plans and emergency mitigation plans that address a multitude, perhaps as many hazards as possible. But climate change is going to impact just about all of them that you've likely identified in your hazard vulnerability assessment already. Obviously, it's impacting weather events, but it's also impacting infectious disease threats, heating and ventilation and air conditioning failure threats, and plenty of others. And then lastly, we should be making an economic case. We can use valid financial modeling to show the economic benefits of climate change disaster preparedness. We should be calculating returns on investment to show the impact on the bottom line to our leadership and our administrators to really make the case that you can choose to prepare, or you can choose to be shuttering your doors and suffering really terrible economic loss at the same time as not fulfilling your mission to your patients and your communities. Amy alluded a little bit to the fact that healthcare can be and should be part of the solution, but it's also part of the problem. This is what I call the non-virtuous cycle of environmental degradation related to healthcare services. Unfortunately, for various reasons, people suffer poor health. They get sick, they need assistance, and they then need to seek healthcare services to try and get better. That's what we do. This is where we really raise ourselves up to the needs of our community. But our healthcare services have a really unfortunate side effect of leading to climate change and environmental degradation. Healthcare is polluting. There is very little that we can do to make it that we do not use any resources. But we need to be cognizant that through environmental degradation and climate change, we are exacerbating the poor health of our communities, leading them, again, to seek more care services and continue the non-virtuous cycle. Healthcare as a whole must work and advocate for improved environmental stewardship to protect our communities, and healthcare needs to lead by example. There is little value or little credibility if we get up in the public and we say, hey, we need to be striving for better environmental stewardship and responsibility across industry and commerce in our country and in our world when we haven't cleaned up our own house to begin with. And the emergency department is no different in that. The emergency department should be part of the solution. And the reality is that up until now, healthcare has gotten a pass. That providing healthcare, improving the health of our communities and our patients has always outweighed environmental impacts. This is exactly the same as we've seen for the last, say, 50 years about the cost of healthcare, that we have not spared expense. We have said, nope, costs aren't a problem until now. For the last number of years, we've really seen greater discussion of improving value and improving the care of our patients while also recognizing the limited resources that we have. I think the same concept is trickling down to emergencies, that treating individual patients has taken precedence over our aggregate environmental impacts, but this is not going to be the case for any longer. It's time for us to recognize that we have limited financial resources and we have limited environmental resources to take care of our people. So let's get a little bit now back into why I, of course, with my completely biased view as an emergency physician, is the specialty to take the lead and to organize our efforts. Emergency medicine touches everything. We are probably the service in the hospital that most consistently interacts with just about every other service. We treat everyone with anything. We are the multidisciplinarians of medicine, which means that we have a perspective on many things and many activities within an institution and across taking care of patients. We see the interactions, we see the holistic picture, and we do it a lot. So this is just a small sampling of specialists with whom I interact on a regular basis. Some certainly more than others. Some I interact on a daily basis, some on a weekly basis, and some maybe just a few times a month. But I can assure you that in the last month I have spoken with residents and attending physicians in all of these specialties to help take care of my patients, which is more than I think many of our colleagues in other specialties do. We do it so much that we don't even think about it. In the United States, we see approximately 140 million emergency department visits a year, representing about 10 to 20% of all outpatient care in the United States. We are responsible for between 5 and 10% of all healthcare expenditures in the United States. So you put those numbers together, and by one model, the emergency department alone is responsible for maybe around 1% of all U.S. greenhouse gas emissions from everything is just from the emergency department. So it's really our responsibility to take a lead here. And we touch on all these different impacts as well. We touch on purchasing. We touch on energy management. We are involved in transportation. Heck, we are the specialists who actually have an entire transportation division within us in the form of EMS. And we certainly generate an ample amount of waste that Amy addressed a little bit earlier. This here is one of my favorite Venn diagrams ever. I like Venn diagrams. I think they're kind of cool. This one I gently borrowed from our colleague Robin Gunther, who is an architect, and she presented this at CleanMed last year. And really the key is that sustainable healthcare is resilient healthcare. This is one of the arguments to be made to our leadership about how environmental stewardship and climate smart healthcare is really good for the institution beyond just the kind of good idea that we should be better stewards. It's that as we are more sustainable, as we reduce our energy requirements and our water requirements, that also reduces the requirements for backing them up. Or if you choose the converse, it increases our ability to operate for a longer period of time with an existing generation and storage capacity. Opting for construction that enables more daylight or natural ventilation also protects us against certain utility losses. So really, sustainable healthcare is resilient healthcare and can help to protect our institutions. I'm here to show you that emergency medicine must take a leadership role in climate change and healthcare sustainability. We can use our expertise to show the rest of healthcare and other industries and the rest of our communities the importance of environmental pollution and climate change and the impact on human health. We can do it by advocating with the public and the lay press. We can do it by advocating among our specialty and among other specialties, and we can do it within our own institutions. But we should take this message and really own it, because we are the leaders in this field. So what you might be thinking about is, are there any tools that I can use to really do this in a data-driven and rational way? The tool that I use the most is life cycle assessment, and some of you may be more familiar with it than others. It's a holistic way of assessing a product or a process from cradle to grave, from raw material acquisition through transport, manufacture, more transport, use, disposal, reuse, all the way through the process, the same way that we in emergency medicine and other specialties strive to take care of the whole patient holistically. This is a way to look at an environmental question from a whole perspective. It's been around for at least 40, now 50 years. There's an internationally accepted standard from ISO on how to perform LCAs, so it's clearly reproducible and reputable. I started looking at LCA in the early 2000s, and the first LCA that I read and really kind of internalized and understood the power of the tool was, believe it or not, about diapers. It was a study done in 1994 by Arthur D. Little, one of my former employers, although I was not there at the time. They were hired by Procter & Gamble to answer the question of whether reusable or disposable diapers were better environmentally. They wanted to market their product to the community. And so ADL went and they did a rigorous analysis, in the end identifying a number of pros and cons with both products on a number of different impact categories. If you're really interested, the key is that it comes down to whether you're in a water-constrained environment or a landfill, land-constrained environment. But of course, this study is now a bit out of date since technology has changed. This is just a sample of what an LCA output could look like. It's generally a comparison tool. You can do an LCA without comparing two products or processes, but it's much more powerful to do it when you are doing comparison. This chart comes from a published study on childbirth, comparing cesarean section birth to vaginal delivery, and in a set of 9 standard categories, things like human health, cancer effects, human health non-cancer effects, lake eutrophication, ecotoxicity, global warming certainly, and climate change. And what you can do is compare which one is better on different categories, since it's rare to have one that's better in all. In this case, that is true, but this is the exception. In most cases, we use midpoint analysis. There are models that can be used to give you endpoints, depending on the purpose of your study, but it's quite a versatile and powerful tool. And it's powerful enough that it can be used in strategic planning. Strategic planning is the process of defining a direction and making decisions that move an organization toward its overarching vision and mission. It requires data and modeling. And if one aspect of your vision or mission is improving your environmental performance, then life cycle assessment can certainly be an input as you perform those models. In addition, and this helps when you're trying to make your case to the people in charge of your organization, LCA techniques are nearly identical to any other holistic accounting scheme, including financial costing. So when you're looking at trying to make a case that we should be improving our environmental performance, and you're presenting to a bunch of people who are used to looking at financial modeling, this is really an identical technique. Now let's step aside and say, okay, I've spent the last 15 minutes or so explaining to you how emergency medicine is really suited to be a leader in this. And now I'm going to tell you in a few seconds how we are immensely behind some of our colleagues. The question is, can we catch up to them? Anesthesiologists have been doing great work in trying to clean the OR. And we see here a bunch of published and completed LCAs. Here we have disposable and reusable surgical instruments, reusable and single-use disposable laryngoscopes, anesthetic drugs, central venous catheter kits, reusable and single-use drug trays. This one was out of Germany. It's on surgical drapes, reusable and disposable surgical drapes, disposable and reusable LMAs. And then the really cream of the crop was Practice Greenhealth creating the Greening the OR checklist, which is a great tool for our institutions to really improve operating room performance. Part of that is just because the operating room is a supreme source of waste and environmental pollution in our hospitals, but as I hope you've taken from this webinar, the emergency department is also a significant contributor, and it's time for us to step up and show that we are the holistic leaders that we can be. There are a number of targets that we can start looking at, some of them being quite low-hanging fruit, where we have multiple clinical options that, for the most part, are clinically indistinguishable to the patient, but might have greater or lesser environmental impacts. Some of that is in reusable versus disposables. Some of it is in how we're disposing of our waste, and some of it is in actual clinical care. As we've seen in the last year or so, as we've identified that we have fewer IV bags available due to, again, climate change related natural disasters, limiting our availability and then switching to more oral rehydration, maybe we can see that we can improve our impact that way. So I hope that I've made a good case that emergency medicine is right at the forefront, and we have the knowledge, the expertise, the tools to lead this. And if you have any questions, please feel free to ask now. Please feel free to get in touch at any time. I'd be happy to kind of bring you along on this journey.
Thank you, Jonathan. I do have some questions that have come in specifically for you, so I think we will start with those. Are there any LCA studies that you would like to do in the emergency department?
Oh, absolutely. I have a nice page-long list of things that I would like to tackle in the emergency department. Certainly, the limiting factor is the energy and bandwidth to do all of them, but the goal is to tackle each of them in turn with some assistance from colleagues within my institution and outside. So if anybody else would like to be involved, I would certainly be happy to collaborate. Since so little has been done in the emergency department, we have a great opportunity to tackle kind of the low-hanging fruit that has been done in some other specialties, particularly anesthesiology, earlier. So we can look at things like suture kits and exam tools like specula. We can look at oral versus IV rehydration. We can look at splinting techniques. And then as we kind of gather more experience and our colleagues see the power of the tools that we have, the goal is to kind of identify more holistic and bigger things that we could model even an emergency department visit.
Great, thank you. Another question has come in, which I will let you answer first, and then I can weigh in. What is it going to take for us to catch up to the anesthesiologist? And I just want to preface that by saying that in our physician network, we do have, at this point, more emergency department medicine physicians than any other specialty, including the anesthesiologist. And I think that really speaks to the great interest there is out there in emergency department physicians really starting to do this work. So Jonathan, I'll let you take a stab at that question. What is it going to take for emergency medicine to catch up to anesthesiologists?
I think the first statement would be that we should all recognize that our say not quite competition with anesthesiology is meant to be entirely friendly, and that really our goals here are the same. We're trying to improve the environmental performance of healthcare as a whole, and we are starting within our own specialties as we branch out. So what can we do to catch up is what I've found in my institution is mostly an awareness thing, that most of my colleagues are really just not thinking about this, not because they don't care, but because it's not an idea that they've been exposed to. And that once they hear about it, a number of them then write to me. For example, the image of that lay press piece that I had on a slide a little while ago, once that was published, I had colleagues coming to me and saying, "Hey, I had no idea that you were interested in that. I had no idea that we could do this. You know, I really want to be involved. How can I help?" And I think gathering that energy is the first step. Finding colleagues who can really take on some of these tasks. Some of it is that the tools needed to perform these studies are I want to say complex but not complicated. That it takes some technical knowledge and learning about how to do an LCA, really to work on that. So part of it is finding collaborators in the environmental engineering and industrial ecology communities to work with if you as an individual environmental or you as an individual emergency physician are not really used to it. And that's totally fine. We collaborate on research all the time with people in different specialties and different industries, and this is no different. So some of it is identifying the collaborators, and I can help people make those connections too.
Yeah, thank you. I want to echo what you said. This is really not a competition with the anesthesiologists. We are in awe of the work they are done. And I think perhaps a better way to frame the question is, how can we learn from the anesthesiologists? And I think we have a lot to learn from them. They have a lot of data. They know about the impact in their ORs. They know about they have purchasing data, waste data, energy data. We don't have that data. They also have done a lot of LCAs, and as of yet, we haven't done them. But again, it's an opportunity that we can do the type of LCAs that the anesthesiologists have done, which has really driven clinical and procurement decisions. Also, the opportunities to reduce the impact of the OR are very well defined and described. They have case studies and lots of resources. I think we could learn from them and create the same sort of resources for emergency departments. And as Jonathan also mentioned, they have this fabulous greening the OR checklist. So I think we really have a lot to learn from our anesthesiologist colleagues, and I thank them for getting us started on this path. Another question that has come in that, Jonathan, I'll let you go first. I mean, what are the low-hanging fruit opportunities in an emergency department?
It's a good question. I would say that I think that most of our colleagues can probably, with a little bit of guidance, identify them just by walking through their departments on a regular basis. kind of the biggest things that I see in my department every day, and I saw them last night as well. We generate a fairly ridiculous amount of red bag regulated medical waste. And without doing a full inventory, I would strongly wager that the vast majority of it does not actually need to be disposed as regulated medical waste. Frequently, that is incinerated, which generates its own toxic pollutants. So that's an easy potential fix to change people's waste generation habits. Another would be kind of some of the disposable items that we use and whether we could switch to more reusable things. That can sometimes be a little bit more challenging as our operations teams might focus on some other benefits of disposables that we don't necessarily have with reusables, things like easy maintenance of par levels and not having to worry about central sterilization. But those are things that can be worked around. Recycling is something that frequently gets talked about. To be honest, it's not a huge impact because many things just don't have the recycling markets that they used to have. But some things really do make a difference, particularly metal, drinking cans and things like that. So having that available in your department is a relatively easy thing.
Great, thank you. We have one other great question that's come in that I'm going to let Lauren Koch answer from Healthcare Without Harm. I'm interested in first making a greenhouse gas inventory for my emergency department. Are there any resources you know of or you can share, or can you share guidance on how to start a greenhouse gas inventory for an emergency department?
Hi all, my name is Lauren Cook. I'm with Practice Greenhealth and Healthcare Without Harm, and we actually just released a greenhouse gas reduction toolkit for hospitals last month for Practice Greenhealth members. So in that toolkit, we have guidance about how to baseline, and we actually have an Excel tool that will help you track the various scopes 1, 2, and 3 that you'll need to do for your greenhouse gas inventory. I will just caution you that that sounds like a difficult task to do it only for the ED, but I'd be happy to share my email and you can reach out to me and we can talk about some strategies. I think the largest area that people often start with on greenhouse gas inventory is energy. And so to be able to break that down by ED, unless you have some sub-metering or a calculation and a way to do that, I think would prove difficult. But there are resources that exist out there. There's also the GHG protocol corporate standard, which is what we based our resource on. And they have tons of free resources available to help you get started.
Great, thank you, Lauren. I think we are going to wrap up now. If your question didn't get answered or if you have any questions in the future, please feel free to contact me and we will get your questions answered. I want to let you know that we have created a climate and emergency medicine resource page on the Healthcare Without Harm website. This page will include links and resources related to each of our webinars, and I encourage you to check it out. You will get a link to this resource page in a follow-up email, which you can expect to receive in the next week or so. If you are a physician, you are getting continuing medical education credits for this webinar series. There's a $15 fee for CME credit. You must register and pay for your CME credit first, and you will get your credit quarterly after you fill out an evaluation survey and submit it. I think that is it. I thank all of you for tuning in today and joining us for our final webinar. Thanks to those of you who joined us for our previous webinars. As I've said several times, please be in touch with me for any questions or comments. Thank you again, everyone.